I mean, I think it's shocking that the hospitals out there say, we want to incent you, so we're going to pay you for WRVUs. And then some hospitals literally come in at the end of the year and say, yeah, you didn't make it. I mean, you'd think if I wanted to incent you on WRVUs, I'd be telling you every day or every week or every month, this is what you're doing. Here's your peer group. Here's the median. Here's what your pay says. If you exceed this, here's what you're, on track to do. But no, I see some that just at the end or say, hey, congratulations, you made $10,000 bonus. Just trust me. You did.
Welcome to How I Doctor, where we're bringing joy back to medicine. Today, I'm joined by Dennis Hursh, an attorney who literally wrote the book on physician contract negotiation. Dennis has spent over 40 years in health law and has personally reviewed more than 3,500 physician employment and locum contracts. He founded Physician Agreements Health Law, the first U.S. firm dedicated exclusively to fixing physician-employer agreements. I came across Dennis through TikTok, and I swear, I'll admit I was not expecting to see him there. I didn't think I'd find somebody talking about physician contract review on TikTok of all places. What I think sets Dennis apart is his commitment to real-world impact. It's born out of deep, hands-on experience negotiating complex RVU-based compensation systems and locums tenens agreements grounded in fair market value and commercial reasonableness. Today, we're going to talk about how physicians can take control of their contracts, from negotiating the right RVU terms to leveraging locum tenens insights, and use that to build careers that are not just sustainable but thriving. Dennis Hursh, welcome to the show. Thank you for being here.
Oh, it's my pleasure. It's great to be here.
Dennis, your story is really personal, from witnessing your daughter's intensive care to launching a law practice for physicians. It's shaped how you negotiate contracts for doctors. How has that journey informed your approach to practicing law?
Well, I think, like most people, being treated by physicians, it tends to be transactional. You walk in, they say, okay, I looked at your labs. Here's what you need. Here's a prescription. Have a nice life. I mean, they're very professional, very friendly, obviously know what they're doing, but it's kind of a transaction. And I think sitting in that ICU, watching the two physicians go all night long, that night really just stuck with me that these aren't transactions. These are people, and they work so very hard. And, I want to do what I can to try and make their life a little better if I can.
Dennis, thank you for saying that, because so many people in the United States are fairly healthy and maybe have never been hospitalized, have never had a surgery, maybe never even broken a bone. Their experience with what physicians do is, like you said, it's pretty straightforward, and maybe it does feel transactional. From my perspective, you're totally right. Like, I think those of us in healthcare, and nurses and pharmacists and social workers, see the level and the depth of which other humans will go to try to help humans who are sick. But because, generally speaking, most people don't see that side of the world, the sense they get is that there is not caring behind that medical degree. Dennis, it's incredible. You've really reviewed 3,500 contracts over your career. Maybe you could just share, like, what are the top one or two things that are patterns or that you've seen in people's contracts that would help them get more money or save them from, a big legal battle if they're, wanting to quit or leave a couple years later?
Well, the things that I see tripping people up a lot are, first of all, they get the story, this is our standard contract. And I know why they do it, because it works. I anecdotally, I don't know, but I'm guessing at least 30% or so of physicians say, oh, if that's your standard contract, so I'll sign it. So they get that. I see start date issues where we'll bring you in, the start date is this. Of course, if you're not credentialed, we'll just delay it fully credentialed. So, you may be credentialed with every payer but one, and it's not really a major payer, but we're not you don't start until everybody's credentialed. So some physician moved into town, is paying rent or paying a mortgage, trying to feed the family. There's no income because, you didn't check that last box, or, the managed care company has taken some time. Physicians ask all the time, the question is, can they enforce this? And my answer usually is, who cares? I mean, enforce in a court, maybe not. That's really extreme. But the problem is, what employer is going to hire you and say, "Yeah, sure, I may get sued by your prior employer, but my attorney says we'll win, so I'm willing to pay whatever it takes and spend however much time in court it takes." I mean, you walk in with a restrictive covenant, it's pretty much anybody but you is who I want to hire. And I think tail coverage trips up a lot of people too. They end up massive. They can't leave because they owe this massive tail, and it's just they're stuck there financially.
How often would you say that you see contracts that either people are sending to you to review or that they've signed that don't have malpractice tail coverage?
Well, it's not that they don't have it; it's silent. But sometimes it specifically says we will cover you during the term of this agreement. And that's it. So read between the lines. We don't cover you after the term of this agreement. And I literally, a good friend of mine, um, left the practice, was a pediatrician moving from California to Pennsylvania, where her husband got a job. And the last day, the office manager came up to her and said, "Oh, by the way, you need to buy tail." And I mean, she had a good job. Her husband had a good job. They'd saved up quite a bit of money for a down payment on a new house. It all went. All the money went for tail coverage and ended up renting for a year or two.
I don't even know I wouldn't even be able to begin to guess. What does a tail coverage cost?
Well, it varies by profession, but
Sure.
I've seen some as much as 3 or 4 months of compensation. So it's a big nut.
Wow.
It's not something that you say, "Oh, here, let me write a check for that." It's gonna be a big nut.
As we've seen more consolidation over, I mean, the almost 20 years since I've been a physician, I mean, with hospitals acquiring other hospitals and merging and growing, does that make the restrictive covenants even more complex because now there's systems that cover a whole region or there's fewer employers at all?
It makes it more important that it be fair. I mean, I see some where the first draft says, "You won't work for any entity that has an office within 20 miles of any office of our system." Now, in the old days, if you were at a private practice with one office, it was no big deal. And the local hospital maybe had, a hospital and 2 clinics. But now you're talking mega health versus super mega health. You could be blocked out if they literally read that correctly. You could be blocked out of literally states, states away because the competitor has an office and so do we, 800 miles from here. So you can't work for that competitor.
Wow. Do you get the sense that, I mean, is this like intentionally nefarious and health systems are trying to kind of nickel and dime and squeeze every little contract trick in the book out there? Or is this just,
There's some of that. I mean, legitimately, hospitals tend to be like sworn enemies of each other, and they're really concerned. They may be more concerned that you don't work for those other guys. Less than, are
oh,
you going to take patients? I hate those people. I don't care if you're moving 200 miles away. No patients are going to follow you. You're working for them, and I hate them, and they're the bane of my existence. So I think there is some of that. And I think that's a lot of it. It's not so much they're saying we don't want you working 3 states away as much as our sworn arch enemy. You can't work for them.
yeah, and it's funny that these entities are the big ones, and that the physician who's delivering the care is just caught in the middle.
Yeah, and again, restrictive covenants are kind of okay. I mean, if you're a primary care physician, you come into an area and we, the hospital, set you up and paid you your salary for 7 months while we were collecting and nobody knew you and we introduced you to the community. That's one thing. But I see it I see radiologists, pathologists, anesthesiologists that have that. And well, I know not to denigrate you, but if you left Kaiser, how many patients do you think would leave with you?
All of them, Dennis, all of them.
I know. Oh, no, I mean, if your mom may stop going to Kaiser, other than that, literally, it's one thing to say, "Look, we introduced you to all these people. You can't take those patients with you." But, as I said, radiologists, anesthesiologists, pathologists, ER people, they're not gonna take any patients. They're not gonna hurt that hospital one little bit if they leave. So in that sense, I think it's just ludicrous.
That's such a good point. The thing that I bring up frequently is that, you know, doctors are not just a monolith. You can't just say doctors. I mean, by specialty, it really does matter. I mean, I think that's such a great point. It does seem like a fairness thing. Hey, if the hospital helped you build your practice and helped you get 2,000 patients on your panel, maybe it is fair that the hospital has some covenant power. But if you're an ER doctor, again, going back to it matters what specialty you're in, maybe that isn't fair at all.
Yeah, in my mind, it isn't at all.
Tell me about these letters you've written on behalf of physicians. I understand you've helped physicians like making thousands of dollars more.
Well, yeah, sometimes because physicians don't really have a good feel for what they're worth. I mean, I've seen instances where literally $50 and $60,000 in salary, and it isn't like you're a special snowflake, so you should get more. It's the MGMA median for somebody in your specialty working at a hospital is $50,000 more, or we give a $10,000 signing/relocation bonus, and MGMA says 50,000 is the median, and 15,000 maybe is the median moving. So that's probably one of the biggest things that I've seen.
So this is really defining value based on a set of data and metrics. This isn't hey, this person's a really good person. This is hey, you
Right.
are objectively in the market underpaying this person, and please
Yeah,
please
yeah.
address it.
I've only once gotten so angry at a hospital I actually said it, but I'm always thinking it is if you don't think this person's a median physician, why are you hiring them? It's like we have a lot of below average doctors in our health system, but they work cheap, so
Oh, I love that. That's amazing. Hey, doctors, AI isn't coming, it's already here. Whether it's scribes, risk prediction, or chatbots, AI is reshaping medicine right now. And that's exactly why I created the AI Secrets for Clinicians webinar. Along with my friend and Valdar Health founder, Dr. Sarah Gebauer, we compiled a practical guide featuring a roundup of the best tools, prompting tips, and educational resources for all clinicians to get started with AI. This is the starting point. You need to learn how to use AI safely, ask the right questions, and take the lead on incorporating this new technology into your practice. Visit offcall.com/AI guide. That's offcall.com/AIGUIDE to get started. Thanks. Literally what we're trying to do is build a data set that is more comprehensive, not just about money and a moving bonus or a signing bonus, but all the other things that also makes a physician job really great or terrible. You can talk to a physician who could say, yeah, a job that's paying $500,000 a year could be incredible, or it could be absolutely miserable. And I know that sounds insane, probably for some people, but you could imagine if you're working 80, 100 hours a week and being driven to the bone and in a high risk specialty, that maybe that is not an enjoyable job anymore.
well, particularly if people are paying $500,000 for that specialty, where you have some life outside of the practice, then it really isn't reasonable. I mean, is it a lot of money? Yes, and I mean, all you did was spend what 30 years in school and save my life. I saw that somewhere that somebody got a 4-star review. It said, Dr. Smith saved my life. And his question was, I don't know what I could have done for that 5th star.
Exactly. How much harder did I need to work to get
Yeah.
that? Let me ask you about RVUs, because I think that's another one of your specialties that you're particularly savvy and knowledgeable about. What are like the top 3 common pitfalls or things that physicians don't understand about whether it's RVUs or WRVUs or just like negotiating when RVUs are part of their pay structure?
Well, some of it is a lot of them don't have the numbers. Like if the median WRVU in your specialty is 9,000 and you're doing 12, two things. Did you know the median was 9,000? And second, did you know you were doing 12? And a lot of times the answer to both of those is no. I mean, I think it's shocking that hospitals out there say, we want to incent you, so we're going to pay you for WRVUs. And then some hospitals literally come in at the end of the year and say, yeah, you didn't make it. I mean, yeah, you know what? I mean, you'd think if I wanted to incent you on WRVUs, I'd be telling you every day or every week or every month, this is what you're doing. Here's your peer group. Here's the median, here's what your pay says. If you exceed this, here's what you're, on track to do. But no, I see some that just at the end or say, hey, congratulations, you made $10,000 bonus. Like, just trust me, you did.
Dennis, maybe you can break down the variance you're seeing in contracts around RVU based pay. So, are people being penalized if they're under? Are they getting, bonuses if they're over?
It's all across the board. As far as I'm concerned, if in your first 2 years, it's fine to have a bonus for WRVU. But while you're building your practice, you shouldn't be expected that here's the target. And if you don't make that, then we're going to penalize you. And I see those. Your salary is $300,000, assuming you produce 9,500 WRVUs. And if you don't, if you do 10% less, we're taking 10% of your pay. And sometimes it's even a payback. It's not next year we're taking next year your salary is 10% less. Sometimes it's like we paid you 300,000, you came in 10% under, you owe us $30,000 because we overpaid you. I mean that's outrageous at any level of practice, but for a new physician starting trying to build a practice, that's just crazy.
Are you seeing people being fully RVU, kind of productivity based? Is it a mix of, hey, we're going to give you this flat salary and there's a kind of you need to hit this metric, but there's a bonus?
I think the most common is we're going to give you a salary, and if you exceed this metric, then we will pay you a bonus. But as I said, I've seen some that say we pay you assuming this many, and we're going to take the money back. I've seen guaranteed, but then sometimes I've seen the numbers roll over past the guarantee period. So we assume again my 300,000. We're assuming 9,500. If you came in at 9,000 the first year, you have a 500 deficit into next year. Well, maybe you're guaranteed 2 years, but if you make 9,500 next year, you had a 500 deficit. You're going into the third year with a 500 deficit, and now you're not guaranteed. So you're starting off, behind the eight ball. So those are kind of things that language is complex, but you got to make sure if you're guaranteed, you should be guaranteed.
Dennis, are the numbers you're seeing with, the median, are those numbers baked into contracts, or is that, an addendum or something saying you will meet the median standard for your specialty?
Oh, no, it's usually a number, it's baked in. So and that's the thing I see all the time is we're paying you a little under median, and if you exceed the 75th percentile of productivity, we'll give you a bonus. There's this gap in there. It's like I'm not even paid median, but you're not even expecting me to produce median. You're expecting me to produce 75th percentile until they don't use those terms, but if you look at the numbers, it's that is close to the 75th percentile before you get a bonus.
And are hospitals setting those medians or those numbers based on national data, or just what their other colleagues in the specialty are yielding right now, or how are
I see national data all the time. I was just looking at one in the upper Midwest, and the national data was like the median salary was something like 80,000, no, $97,000 less. In the upper Midwest, the median compensation is pretty close to the 75th percentile nationwide. And they come in and they say, we're using national percentages. My point with that is always like, great, I always wanted to live in Hawaii. I'll just call it in. You don't care, obviously, since you're using national. I should be able to live anywhere in the country. They usually don't feel that way.
imagine that. One of my hypotheses I've had about physicians not being aware of their RVUs, or I think generally a mistrust of knowing if their RVUs are being tracked or assigned appropriately or fairly, is that, the same system that is handling medical billing, the internal version of that is assigning RVUs. And so, in the same way that we know the medical billing system is very challenging in the United States, I would imagine those same challenges exist for assigning RVUs correctly to the right doctor within a reasonable period of time as well.
It is, and I mean that's one of the things I always shoot for. Is I think that your WRVU should be earned in a date of service. I actually had a case where apparently Susie in billing was out pregnant, and so basic as far as we're concerned, you didn't work for 6 weeks because you had nothing. No WRVUs were credited because we didn't bill any of your WRVUs. So, I mean, that's a big thing. And you talk about hospitals, it's not I don't know, but it's unreasonable. I mean, if I put you in charge of the accounts receivable for a hospital and you've got all these six-figure ICU bills, and then you've got this physician saw, a patient, and that's $230. I mean, which one are you gonna be chasing? You know
Yeah, that's a great point.
yeah, so it's not necessarily poor business on their part, but I do think sometimes they're ridiculous with it. Now, I don't think this physician really knew the exact number, but I just had a physician tell me he was pretty sure that the hospital was missing between $2 and $6 million a year on physician billings. Now, I'm not an MBA, but it seems to me I would pay somebody $30,000 a year to go after those. It seems to me that would be a good business decision, but, that's why I don't work at a hospital.
Dennis, how can physicians get more transparency into the process and clearly understand the WRV rates and CPT guidelines?
I used to rant and rave about this, but now I realize that it's been going on so long. I think I still feel the modifiers shouldn't be applied. I don't argue with the concept of reimbursement for a modifier. I mean, if you're a surgeon and you do a bilateral procedure, I get that the hospital should get less. They prep the OR, the anesthesiologist is there. I get that maybe that shouldn't be reimbursed at the same level as twice a single procedure. But as a physician, you did twice the work.
Exactly. Yeah.
It's like I don't argue with the reimbursement issue, but I don't think that your WRVU should be impacted. Having said that, I've actually spoken to MGMA and they get the reports from the hospital. So nowadays, it's pretty much assumed that those benchmarks have modifiers baked into them because that's what the hospitals are reporting. And some of the things you have to ask to get reports. I represented a physician who was told, we're probably going to fire you because you're at your 10% productivity levels. You're horrible. And he finally got them to give them report. They weren't required to give reports. I basically nagged him to get reports. And we looked at his schedule. There were many days. This was a fully booked cardiologist, was seeing, I don't know, 15 or 20 patients a day. He
Sure.
had several days that he was credited with 2 visits. I mean, we literally had
Wow.
to go in and say, "Look, here's the schedule." I it was a lot more than 20, but you just wonder what else is going wrong, in that hospital if they're that messed up. And I've gotta think they probably didn't bill those 18 patients. I don't know, but
Yeah.
it was just a mess.
Typically, how easy is it for physicians to get their download of their RVUs for the day or the week? Do you find that's pretty simple or not simple at all?
Something I asked for in the contract. It should be given to you. You shouldn't even have to do it. It should come in and say at least monthly, okay, here's your report. A lot of places will and say, here's yours, here's peer comparisons, here's what you did. But a lot of places you have to ask for it. It's like we'll tell you at the end of the quarter if you made a bonus or not.
From your perspective, looking at so many contracts, do you think the RVU model is a trap for physicians, or is it fair?
I don't know if I'd say a trap. I mean, it certainly it pays you for the work you do to a certain extent. I mean, I do think I'm not sure it's the best model for quality of care. If we're trying to keep your numbers up and you've got those patients scheduled, you better keep on schedule, or you're going to fall back and your numbers are going to decline. So, maybe 15 minutes wasn't enough for that elderly woman with 16 comorbidities or something. But so I'm not sure it's the best for quality of care, but I think it is an attempt to say, are you working or aren't you working? So I sort of see where it's coming from, but yeah, I think for a lot of physicians, it's a trap.
Well, I think your point about the elderly woman with lots of comorbidities often does not get built into the level of complexity. I agree. I think a system that incentivizes people to quote unquote work harder is not a bad system at all. But you hit the nail on the head. Like if if I'm being paid the same amount to see a 23-year-old with lower back pain and a 95-year-old with lower back pain, those two are extremely different people, require extremely different amounts of work and thought and, comprehensiveness to my plan, but, they're all paid at the same rate or something like that.
Well, and the other thing is, again, in sending you to work hard is okay if we have the work for you. If we hired 3 endocrinologists and then the private practice across town hired 3, and it turns out there just aren't that many patients, from the hospital's perspective, it's like, it's no big deal. We just won't pay the physician. So, it's fine. But it's not my problem.
That's fascinating.
Yeah.
Dennis, if a physician has a choice between salary, RVU, some mix of, salary base plus RVU, do you ever give them a recommendation, or does it really depend on each individual's values and goals and stuff?
I think everybody should get a reasonable salary. And then I think you should get productivity if you exceed that. But I think the concept is you should know what you're going to earn and it should be a reasonable amount. And then, sure, if you work above and beyond, I think it's completely fair to compensate you extra. But again, you can only work if the patients present. If you have a slow day because there was nobody there, that should not be your problem.
Physicians often don't also realize just how much is also being billed under their NPI. So it's not just the CPT code that they're documenting, but all of the additional services that they're ordering that are then the hospital is billing for, whether it's an x-ray or a CAT scan or an ICU stay. I think there's a sense that, the physician is only quote unquote worth, whatever they're getting paid. But the physician is also, like, physicians control like 90% of the healthcare spend. And physicians, maybe the hospital's making $10 million off me and only paying me $300,000 a year. Well, hey, the hospital's doing pretty good for what they're paying me.
I think the bottom line is you're right. It's like we separate it into just what you're doing. And then, I get that all the time. I have physicians being told, we're losing money on your practice. And, and I think what they mean is what you personally are billing, and the cost of the rent and, your assistants and everything is more than we're bringing in. But, you look at it and say, well, sure, you get a lot of broken bones. You do x-rays, occasional MRI, occasional CT. You admit people to the hospital. But yeah, they say we're losing money on you. And it's just, no, you're not. Most of the time, no, you're not.
Yeah, exactly. Dennis, you mentioned the Stark Law, and I wondered if maybe you could explain that to our listeners. I know a little bit about it. I understand it causes lots of interesting, complex incentives and unintended consequences. Can you just maybe give me an overview of what the Stark Law is?
Well, the Stark Law basically at its core just says it's illegal to pay or receive money for a referral. So you can't say, hey, as a specialist, I'll give you $50 for every Medicare patient you send me. And the theory is because if you were getting referrals, you are going to build that into your expenses and Medicare is going to pay more money. So the theory is good, but then you think of all the clever ways that people can do. I don't have it in my drawer anymore, but the Stark 3 regs, double-sided, were like that. And because people think of clever ways, hey, I'm a surgeon, you're a primary care physician. How about we let you buy into the ASC for $20? And of course that means the more you refer to the center, the more you make. So all these like incredibly convoluted options have been addressed. And I do think sometimes people just get crazy about it. And the thing that I love is it applies to locum tenens. You have somebody comes in from 5 states over, has privileges at one hospital. Now, how can anybody say you're paying him or her for referrals? Where else is he going to send his patients? It's absurd to say if we don't very carefully watch what we're paying you, it's part of it's going to be for a referral. It's like, no.
Wait, explain that to me. I don't even understand what's the concern there? So say I take a locums job I live here in California. I take a job in Kansas. What's the worry there?
Well, that you're being paid for referrals. So if we say, hey, this is the median compensation for you, why are we paying you more? And the
Oh,
concern is the regulator will say, because you're referring, that's where the money is. But again, you think about that, it's like you had no place else to refer. It's not like, hey, give me some money or I'm going to send it over there. You have privileges at one hospital. You're not going to send anyplace else. So I think it's absurd to say we're paying you for referrals in that situation. That paying you more than median or paying you even a lot of money is somehow related to referrals.
yeah. Okay, that makes sense. Yeah, I had Mark Cuban on the podcast a couple months ago, and his point was just that healthcare companies, whether it's hospitals or pharma or payers or medical practices, doctors groups as well, these groups will always be able to outmaneuver a law. I mean, that's just the nature of, the legislative branch of government. They can't, constantly pivot and patch laws as fast as companies can find loopholes around them, which is, his point of this was that's just the challenge of we need to structure our healthcare system and the way that we pay for things differently because you're never going to find United is really smart. Optum is really smart. They know what they're doing.
Yeah. I think sometimes hospitals use Stark as a defense. And in the old, I show my age, but used to be the only thing I was practicing before Stark, and it used to be hospitals worried about private enrollment. And the concern was we can't fix the toilet in the doctor's lounge. That's private enrollment. Well, no, it isn't. And I think some of that's the same. Like I said, the locum tenens, we can't pay you more than X because that's going to be a Stark law violation. It's like, no, it's not. I mean, it's a nice excuse, and they use it. They tend to, bring it up and say, "Ooh, Stark," "Oh, can't do it, Stark," and everybody says, "Oh, no, we violate Stark." They don't say why. Why did it violate Stark?
Yeah, so let's talk about locums because I'm seeing a growing trend of physicians using locums jobs to make more money and I think probably some work fewer hours, work harder in places that they don't wouldn't choose to necessarily live long term. Tell me about what the contract challenges are with locums and what trends you're seeing there.
Well, the biggest trend I see is that physicians are not being paid fairly, that there's a lot of money. A lot of times I'll say people want to leave early and they say, what can they do? Um, and I'll say, well, they could charge a locum tenens and say, you cost us that, that's damages. And usually, and physicians will tend to brush that off and say, locum tenens don't make much. Well, maybe the locum tenens physician doesn't make much, but those locum tenens companies do. I was at a conference for FlexMed staff a couple months ago, and one of the physicians there inadvertently got in an email chain that she wasn't supposed to be in, and she saw the numbers, and I find this stunning, but she said she saw the numbers. It was 7 times what they were proposing to pay her was what the locum tenens company was getting. Um, the hospital needed the specialty really badly, and the locum tenens company struck a great deal, and then thought they'd strike a great deal with the doctor too. And I mean, it was decent. According to her, it wasn't horrible money. It's just the locum tenens company knew these people really had a desperate need and needed it now, and they were cashing in on that.
Do you have a sense of what numbers the locums agencies are charging the hospital and then I mean, it sounds like it's almost arbitrage, like the arbitrage to then getting the physician for I assume what is like maybe a 3, 6 month, year-long contract or something?
Sometimes or even less, yeah. Yeah, I mean, I've seen 2-year, but yeah, it's relatively short. I don't have a good sense. One of the trends I've seen, and again, I think FlexMed staff is somebody that's kind of pushing that, is that the physicians independently contract with. So you go out and you see this hospital is looking for my specialty. They'll call and say, "Hey, would you be interested in a locums?" And a lot of times they will, and a lot of times they're really willing to strike a deal because they're talking to locum tenens companies that are quoting them 2 times what you would make, so you can make a very reasonable income, and the hospital's saving money too.
Yeah, so you just have the physician is just a free agent and going to the hospital and saying, "Hey, why don't we cut out the middleman and you can pay me more than the staffing company was going to pay me, and you can also save some money as well. We'll split the difference to some degree."
Yeah, yeah.
How do locums physicians negotiate better, especially if it sounds like a lot more of this data is behind closed doors and hidden to them? How do you find that they're able to negotiate?
Well, I have a process I use where I look at the MGMA benchmark and then for an employed physician and then gross it up. And I think that'll come to like a reasonable minimum hourly mark. So, I figure salary and benefits are 30%. So, take right off the bat, you do that. You look at an employed physician's PTO and you take that, there's 2,080 hours a year. If you get 80 hours of PTO, then for $2,000, this is what you get. Um, and I think that's fairly non-controversial. I mean, when I start talking about benchmarks, I think it's hard for you to say, well, no. And the one I love, I've never had a hospital come back. Someday somebody will. Is like the dirty secret is, it's 2,080 hours a year is 52 40-hour weeks. The dirty secret is our physicians get 120 or let's say 80 because I'm not good at math, 80 hours of PTO. A smart CFO is going to say, well, our physician, that's not the, we work ours to death. I mean, they eat, see patients and chart. That's been sleep a
Yeah.
little bit. But I think that'd be a very strong argument, but it's like, oh yeah, I'm really interested in coming there. That sounds like a great place for me.
Dennis, with off call, we are trying to figure out a apples to apples comparison. And part of the challenge is all these physicians are paid very different ways, just like we've talked about. Some are salaried, some are RVU, some are. I've even talked to some orthopedists who are get a percent of collections. If you had to find a way for a physician to compare two jobs, like what do you think the best fair comparable metric is? Is it just hourly? Is it pay per shift or
MGMA also has dollars per WRVUs. But one of the things, like I love telling this to gastroenterologists, but one of the things I always say is don't the money shouldn't be a major concern. A lot of times you may not even be able to tell me why you liked those folks better than those folks, but trust your gut. And there's no free lunch. I mean, these guys pay you more. Well, I guarantee you they're going to work you harder. You're going to have less PTO, less CME. There's no free lunches out there.
yeah, it's interesting. That's part of the challenge I think for many physicians and physician jobs is there's so much qualitativeness and like just the feel and the Gen Z vibe. It's the vibe of the place that is really determining if you're happy with this place, and the money is certainly important. It's not an afterthought, but it's only one of many considerations at a job.
Yeah, and after when you're coming out of school and you've got, hundreds of thousands of dollars of medical debt, I can see being focused on the money, but in a couple of years, at some point you may expect to have an actual personal life. And if you do, now's the time to look at that job and say, is that a possibility here? I make a killing, but is it going to kill me?
Dennis, how are Medicare payment schedules and MGMA reporting and Stark enforcement? How is this all bundling up to reshape the future of physician contracts?
Well, I'm a little jaded. I think some of it hospitals use to their advantage. They'll say, "Oh, well, we can't pay you more than the median," and by which we mean the national median. Even though we're in northern Michigan, where nobody wants to be, and we have to pay you a fortune to get there. And Stark law, I think, many times is an excuse. That it really we're not really worried. We can't possibly pay you more than this because if we do, it's Stark. No, it isn't. Um, yeah, so you can't look at if the hospital's making money, and Stark doesn't expect you to. Stark says, is it commercially reasonable? And it may not be. if you're an emergency room doctor, we want an ER. You may be on a night shift and hardly anybody comes in. One guy came in with a sprained ankle. So we can't pay you much, because all we got was that sprained ankle. Well, no, you got an open ER.
Yeah, you're paying for my availability.
Yeah, exactly. And, do you want to close your ER? I mean, can you even close your ER, for a nonprofit hospital? Yeah, did we lose money on you? Well, maybe we paid you more than you brought in, but that's not losing money, having a hospital.
Do you ever have a sense that in the future, physicians and hospitals will collaborate more as opposed to I just pay the bill, I pay you to do this job?
I'd like to think so. Realistically, I just don't see it. I mean, the way we're set up, those hospitals, and I don't care, you can call them nonprofit all you want. You've got nonprofit hospitals where the CEO is making $8 million a year. Okay, if you want to call it a nonprofit because it doesn't have shareholders, you can call it that. But I just think it's a business, and physicians are one aspect of what I, as a businessman, have to purchase in order to sell and make money. So I think, you would hope that it would be quality of care and say, hey, if we put our heads together, we can give much better patient care. But I just don't, I mean, I'm not wildly optimistic about that. No.
I mean, I wonder if some degree of transparency will influence negotiation further. That, I think that the younger generation, and I'm talking about people younger than me as well, I think are way more open to transparency. I think, you know, traditionally, a lot of professionals don't want to talk about how much money they make or how many hours they work. But I think the younger generation has a very different look about transparency and fairness, and they're way less concerned about being hidden about what they do.
I think it helps, and it's definitely a good first step. But, as I said, it just seems like physicians are really focused on quality of care, and hospitals, I think that's on our mission statement and everything else. But the bottom line is, what do they say? No money, no mission. Bottom line is we got to be making money. And that's always going to be a dichotomy. It's hard for me to imagine a hospital ever saying, all we care about is patient care, and quality.
Exactly. Well, Dennis, I want to thank you. You've offered, I think, a 10% discount for off-call users who want to use your services. It's extremely generous. What is the best way for someone to get in touch with you and decide if they want to engage with you?
Well, probably there's a lot of information about what I do on the website. It's PA, as in physician agreements, healthlaw.com. So pahealthlaw.com is probably the easiest way to get a hold of me. She said I'm on TikTok too.
I was going to ask, how did you decide to get on TikTok?
Just I had somebody talking to me and said, there's no lawyers on TikTok. You should do it. And it was kind of a dare.
Well, it is fantastic. I'll be 45 in a few months, but I am just amazed at how many young physicians and medical students are on there sharing their journey in a way that I never would have shared my journey. Well, Dennis, I just want to thank you for your time. This has been an incredible discussion. I feel like I learned so much about RVUs and locums and incentives and the Stark Law. It's just been absolutely fantastic. Thank you so much.
Sure, it was my pleasure.
Thanks for joining me today. For interviews with physicians creating meaningful change, check out offcall.com/podcast. You can find How I Doctor on Apple, Spotify, or wherever you listen to podcasts. We'll have new episodes weekly. This has been and continues to be Dr. Graham Walker. Stay well, stay inspired, and practice with purpose.